I want you to put yourself in a highly specific, incredibly stressful situation.
Oh, I think I know where you're going with this.
Yeah, you probably do. It is 2 o'clock in the morning. The house is completely dark, completely quiet, except for the sound of your child or, a child you are caring for, just tossing and turning.
Right. That dreaded midnight wake up.
Exactly. You go in to check on them, and they are radiating heat, a soaring fever. So you do what any responsible parent or caregiver in the world would do.
You go straight to the medicine cabinet.
You go to the medicine cabinet, you grab the bottle of standard, over-the-counter pediatric ibuprofen or paracetamol. You measure out the exact dosage for their weight, and you give it to them.
Because you expect the fever to break.
Right. You expect them to settle down and go back to sleep. But an hour later, you check on them again and the fever hasn't moved. And worse, you pull back the blanket and their entire chest and arms are covered in these angry, raised red hives.
Oh, wow. That's terrifying.
It gets worse. You look at their face and their eyelids are starting to swell shut. In that moment, staring at this sudden, terrifying physical transformation, what is the very first thought that fires through your brain?
I mean, the absolute unquestionable conclusion in that moment of panic is that the child is having a severe, potentially life-threatening allergic reaction to the medicine you just poured down their throat.
Right. Because you just gave it to them.
Exactly. You gave the medication, and the reaction happened almost immediately afterward. The human brain is just, it's hardwired for that kind of pattern recognition. Cause and effect.
It is the most logical assumption you could possibly make. The drug caused the allergy. But we are dedicating this entire deep dive to a reality that completely shatters that assumption.
It really does. It turns the whole thing upside down.
Because according to the most comprehensive medical data we have, if you find yourself in that exact 2 a.m. scenario, your assumption, that terrifying label of a drug allergy, is going to be wrong more than 80% of the time.
Which is just a staggering statistic. I mean, it completely upends how we think about causality, immune responses, and, well, the way we diagnose children versus the way we diagnose adults.
Over 80%.
Yeah. If we connect this to the bigger picture, we realize that childhood immune responses are a moving target. We're looking at a situation where a massive portion of the pediatric population is walking around with a medical label that is fundamentally incorrect.
And today, our mission is to unpack this massive diagnostic illusion. Okay, let's unpack this, because we are looking at decades of clinical data and heavy-hitting medical research to really understand this.
We have some incredible sources on the table today.
We really do. We have data from a multi-center study by the European Network on Drug Allergy across 6 different European cities. We also have a deeply focused historical perspective study by Cousin and their team that tried and basically failed to categorize these kids using adult medical rule.
Right, that one is fascinating.
And finally, we have the official position paper from the European Academy of Allergy and Clinical Immunology detailing exactly how doctors are actually supposed to handle this.
It's the official rule book, essentially.
Exactly. So we are going to explore why children are misdiagnosed at such astronomical rates, why the underlying biology of a child makes adult diagnostic rulebooks completely useless, and what it actually takes to figure out who is truly reacting and how to keep them safe.
And I think we have to start by addressing that 80% number directly, because it challenges the very foundation of clinical observation.
So let's look at the data driving that number. The NDA, the European Network on Drug Allergy, pulled together this massive study looking at 693 children.
That is a huge sample size for this kind of specific allergic presentation.
It is. And this wasn't just isolated to one hospital in one city. They gathered data from clinics in Belgrade, Florence, Geneva, Madrid, Porto, and Rome.
And that geographic spread is essential for a study like this. I mean, when you are trying to understand an immune response across a population, you have to account for different environmental factors.
Right, like weather or local bugs.
Exactly. Different prevailing viral strains in different climates and fundamentally different medical cultures. The way a pediatrician practices in Madrid, it can be quite different from a pediatrician in Belgrade.
That makes sense. So you have almost 700 children from across Southern and Central Europe, all of whom walked into these clinics with a documented history of an NSAID reaction.
They had the medical label.
Their caregivers, and often their primary doctors, firmly believed they were allergic to non-steroidal anti-inflammatory drugs, like ibuprofen. To prove it, the researchers put every single one of these children through the gold standard of allergy testing.
The drug provocation test.
Right. They administered the suspected drug in a highly controlled hospital setting. And out of all those kids, only 19.6% actually had a confirmed hypersensitivity reaction.
Less than 1 in 5, meaning that over 80% of those children who had been carrying this terrifying diagnosis tolerated the drug perfectly fine in a controlled environment.
So the initial reaction they had at home was what? Just a false alarm?
It was a complete false alarm. The drug was essentially innocent.
So wait, if I'm reading this data and I see that over 400 kids were blamed for being allergic to a drug that is actually perfectly safe for them, I have to ask, what actually caused the hives that night at 2 a.m.? I mean, the parent didn't hallucinate the swelling. Something happened.
Something absolutely happened. But the drug was essentially an innocent bystander that just, got caught at the scene of the crime.
Okay, so who committed the crime?
To understand this, we have to look at the cellular reality of a young child. Children, especially toddlers and preschoolers, are exposed to just a relentless barrage of viral infections.
Oh, absolutely. Daycares and schools are basically petri dishes.
Highly efficient mixing environments for adenoviruses, enteroviruses, rhinoviruses, and things like roseola.
Just the constant runny noses of childhood.
Precisely. Now, when a child contracts one of these viruses, the immune system mounts a defense. It deploys T cells and releases inflammatory chemicals called cytokines to fight the invader.
Okay, standard immune response.
Right. But in many of these common childhood viruses, a natural byproduct of that systemic immune fight is a localized inflammation in the skin.
Wait, really? So the virus itself causes the skin to break out?
Yes. In medicine, we call it a viral exanthem. The skin erupts in hives or a rash, purely driven by the viral infection and the immune system's response to it. The drug has absolutely nothing to do with it.
But the timing is so specific. The parent gives the ibuprofen and the hives appear an hour later. Is that just like the worst luck imaginable?
It is a phenomenal coincidence of timing that tricks the human brain perfectly. Think about the natural life cycle of a viral fever.
Right.
The fever starts, it climbs, the child feels terrible. The parent administers the antipyretic, the fever-reducing drug. Right around the time the fever hits its absolute peak, which is usually when the parent is most desperate, and giving that second or third dose of the medication is often the exact phase in the viral life cycle where the immune system triggers the skin rash.
Wow. Okay, it's like blaming the fire extinguisher for the fire.
Oh, that's a great way to put it.
I mean, the child has a viral fire burning inside them. The fever is the heat of the fire. You hand them an NSAID, which acts like a fire extinguisher to cool the fever down. But right as you use the extinguisher, the viral fire causes the skin to blister into hives. And because you happen to be holding the extinguisher when the hives appear, you blame the extinguisher.
That is exactly what is happening. It's the logical fallacy of post hoc, ergo propter hoc, after this, therefore because of this.
Right, correlation isn't causation.
Exactly. The parent sees the sequence of events and assigns blame to the most visible intervention. In immunology, we refer to these underlying viral infections as cofactors. The virus is the true driver of the visible symptom, but because the drug is present, the drug gets the permanent medical label.
And we really need to pause and look at the real-world impact of that label. Because on the surface, if a parent thinks their kid is allergic to ibuprofen, they just stop giving them ibuprofen. It seems like a minor inconvenience.
Better safe than sorry, right?
That better safe than sorry mentality is exactly what leads to the massive overdiagnosis. But the burden of carrying a false drug allergy is profound. It goes far beyond a minor inconvenience.
I mean, we are talking about banning a child from using the most effective, accessible, and scientifically proven medications for pain and fever on the planet.
Exactly.
If you slap an NSAID allergy label on a 3-year-old and they carry that into their teenage years, what happens when they break their leg playing soccer? Or what happens when they need their wisdom teeth removed? You severely restrict the physician's toolkit. If classic NSAIDs are completely off the table, a doctor managing a fracture or post-surgical pain might be forced to skip the safest non-narcotic options and prescribe opioids.
Oh, wow. And we know how dangerous that can be.
We are intimately aware of the societal and physiological risks of opioid exposure, particularly in adolescents. Alternatively, the doctor might prescribe nothing at all, leaving the child to suffer through unnecessary pain.
There is also the financial and psychological toll on the family. Every single time that child gets a minor injury or a fever, the parents are thrust into an anxiety spiral.
Terrified of over-the-counter medications.
Right. Perhaps rushing to the emergency room for alternative treatments that cost exponentially more money and time.
Which is why the European guidelines emphasize that shedding a false allergy label is a critical medical intervention. You're literally giving that child their pharmacological safety net back.
But clearing the false alarms still leaves us with the reality of the 20%. The roughly 1 out of 5 children in this massive study who didn't just have a viral cofactor.
Right, the true positives.
They took the drug in the hospital under observation, and their bodies genuinely reacted. To protect those kids, we have to know exactly what is triggering them.
We have to identify the specific culprits within the NSAI family.
And the data on this is fascinating because it is heavily influenced by geography. Across almost all the European centers in the study, Madrid, Geneva, Porto, Belgrade, Florence, the absolute #1 drug that triggered these confirmed reactions was ibuprofen.
Which is statistically predictable, really. Ibuprofen is the primary workhorse for pediatric pain and fever management in most of the Western world.
So just by sheer volume.
Right. If more children are exposed to it, you will naturally capture a higher volume of genuine reactions to it.
But the data from Rome completely flipped that expectation. In the Rome clinics, the most frequently reported trigger wasn't ibuprofen, it was paracetamol.
This is a perfect example of how local medical culture heavily skews diagnostic data. The underlying biology of a child living in Rome is fundamentally identical to a child living in Madrid.
The immune systems operate on the exact same principles.
Exactly.
So why is the Roman data so different?
Because of the prescribing habits of local pediatricians. If the medical consensus in a specific region, in this case Rome, dictates that paracetamol is the absolute first-line defense for any pediatric fever, then the children in that region are going to be exposed to paracetamol far more often than ibuprofen.
So it's purely a numbers game?
It is a pure numbers game. The more a population consumes a specific compound, the more hypersensitivity reactions to that compound you will document.
That makes total sense from a population level. But wait, when I look at paracetamol specifically, I hit a biochemical wall here.
How so?
The sources are very clear that paracetamol, which listeners in North America will know as acetaminophen, is not a classic non-steroidal anti-inflammatory drug. It doesn't fight inflammation in the same way. So if it operates differently, why is a child who's reacting to classic NSAIDs also reacting to paracetamol? Why are we lumping it in here?
That is a crucial pharmacological distinction. You have to look at the enzymes these drugs target. Classic NSAIDs, like ibuprofen or aspirin, are blunt instruments. They aggressively inhibit enzymes called cyclooxygenase 1 and cyclooxygenase 2, commonly known as COX1 and COX2.
And what do those enzymes do normally?
They are part of a massive biochemical pathway that produces inflammatory chemicals. When you sprain your ankle, these enzymes ramp up production to create swelling and pain.
Which is your body's way of forcing you to stay off the ankle so it can heal.
Precisely. Classic NSAIDs block those enzymes systemically, reducing the swelling and the pain.
But paracetamol doesn't do that.
Not effectively, no. It has very weak anti-inflammatory properties in the peripheral tissues, like that swollen ankle. However, paracetamol is highly active in the central nervous system.
In the brain.
Yes. It crosses the blood-brain barrier and acts on the hypothalamus to reduce fever. Now, pharmacologists heavily debate the exact mechanism, but the leading theory is that paracetamol acts on a variant of these enzymes, sometimes referred to as COX3, or specific splice variants of COX1 within the brain.
So it isn't identical, but it is interacting with the exact same family of enzymes.
Exactly. It is poking at the exact same cyclooxygenase pathway, just in a different location and with a slightly different mechanism.
I see.
And because it interacts with that same metabolic pathway, its side effect profile from an allergic standpoint is extremely similar. If a child has a metabolic flaw that causes them to react violently when COX enzymes are inhibited, a high dose of paracetamol will often trigger the exact same reaction as a dose of ibuprofen.
Okay, so there are different tools, but they break the same pipe in the immune system.
That's a great way to visualize it.
So when that pipe breaks, what does the reaction actually look like? The parents in our 2 a.m. scenario saw hives and swelling. Is that the standard presentation for these true confirmed reactions?
The clinical presentation is overwhelmingly cutaneous. It happens on the skin. The multi-center data showed that nearly 87% of the children who had a confirmed initial reaction manifested it solely through skin symptoms.
87%. Wow. And we're talking primarily about urticaria and angioedema. Can we break those down? Because they sound similar, but physically they're quite different.
Urticaria is the clinical term for hives. These are raised, red, intensely itchy welts that appear on the superficial layers of the skin.
Okay.
They are caused by histamine and other chemicals, causing tiny blood vessels near the surface to dilate and leak a small amount of fluid.
And angioedema.
Angioedema is a deeper, more profound swelling. It occurs in the lower layers of the skin and the underlying tissue, or the mucous membranes. It is less about itchy red welts and more about significant fluid accumulation.
So actual structural swelling.
Yes, often resulting in severe, visible deformity of the affected area.
And this brings us to a highly specific, almost jarring detail from the clinical data. When these children and teenagers experience this deep swelling, this angioedema, it frequently manifests in one very specific location: isolated periorbital angioedema.
Swelling that is strictly localized to the area surrounding the eyes.
Right. And if you think about taking a pill that you swallow, it goes into your stomach, into your bloodstream, and travels through your entire body. Why on earth does the immunological explosion happen exclusively around the eyes? Why wouldn't their legs swell or their hands?
It comes down to the microscopic anatomy of the human face and fluid dynamics.
Fluid dynamic.
Remember, angioedema is driven by inflammatory mediators, causing capillaries to become highly permeable. They leak plasma into the surrounding tissue.
Like a soaker hose in a garden.
Exactly. Now, fluid will always follow the path of least resistance. The skin around the human eye, the periorbital tissue, is some of the thinnest skin on the entire body. Furthermore, there is very little subcutaneous fat and loose connective tissue acting as a physical barrier in that area.
So when the vascular system starts leaking plasma throughout the whole body, the tight, dense skin on your legs or arms physically holds the fluid in check.
Right.
But the thin, loose skin around your eyelids just balloons outward.
It has zero structural resistance.
Yeah.
The fluid pools rapidly in that loose connective tissue, leading to dramatic, highly visible swelling. A teenager could take a dose of ibuprofen for a sports injury, and an hour later, their eyelids are swollen completely shut, looking like they've suffered major facial trauma.
While the rest of their skin looks entirely normal.
Exactly.
It is a terrifying presentation. But clinically, it is a massive clue for the doctor. Because once a doctor sees that swelling, and they confirm that the child is truly reacting to the drug, the next necessary step in medicine is classification.
And classification is the bedrock of modern medicine. You cannot treat an illness optimally until you know exactly what category of illness you are dealing with.
But here's where it gets really interesting, because this is where the entire medical establishment hit a brick wall. They tried to classify these children, and the system broke.
They were applying an adult framework to a pediatric patient, which is, frankly, a historical flaw in medicine. For decades, children were often treated pharmacologically and diagnostically as miniature adults.
To understand how spectacular this failure was, we have to look at the study by Cousin and their team out of France. They gathered 107 children who had absolute, undisputed, confirmed hypersensitivity to NSAIDs.
There were no viral false alarms here.
Yeah.
These kids were genuinely reacting.
And the researchers attempted to drop these 107 children into the standard adult NEA classification system. Now, to give you context, the adult system is highly structured. It categorizes patients into 5 distinct groups based on the timing of the reaction, whether they have respiratory or skin symptoms, and crucially, whether they have underlying chronic diseases.
So you have these 5 adult buckets.
Right. You have 5 adult buckets and you have 107 allergic children. And when the researchers tried to sort them, they found that 40.2% of the children, almost half of them, could not be classified at all.
They simply didn't fit into any of the 5 buckets.
The adult taxonomy was completely useless for nearly half the pediatric population.
It was a vital piece of research because it quantified a frustration that pediatric allergists have been experiencing for years. It proved mathematically that you cannot use adult immunological criteria on a child's body.
But why not? Why does the adult math fail so completely? If an adult gets hives from ibuprofen and a child gets hives from ibuprofen, why aren't they in the same bucket?
Because the adult buckets are defined heavily by the presence of long-term chronic diseases. Let's look at the 2 largest categories in the adult classification system. One is called NERD, NSA exacerbated respiratory disease. The other is NECD, NSA exacerbated cutaneous disease.
So one affects the lungs, one affects the skin.
Exactly. But to be placed into the adult NERD category, it is not enough to simply wheeze when you take an NSAID. The vast majority of adults in this category have severe underlying respiratory conditions. They have late-onset asthma, and they suffer from chronic rhinosinusitis with nasal polyps.
Nasal polyps, those are those benign growths inside the nasal passages, right?
Yes. They are fleshy swellings of the mucosal lining. Now, think about a pathophysiology required to develop a nasal polyp. It requires years, sometimes decades, of continuous chronic inflammation to remodel the tissue to that extent.
Ah, I see.
There is a classic clinical presentation in adult allergy known as Samter's triad. It consists of asthma, aspirin sensitivity, and nasal polyposis. It is a highly reliable marker for adult NSAID hypersensitivity.
But a 5-year-old child fundamentally lacks the time required to develop Samter's triad.
Precisely. A 5-year-old has an evolving, immature immune system. They have not lived long enough to subject their sinuses to the decades of chronic inflammation required to grow polyps. The medical literature points out that true Samter's triad is almost never observed before the age of 13.
That makes total sense.
Similarly, late-onset asthma is, by definition, an adult pathology. Even for the skin category, NSAID, adults are required to have a history of chronic spontaneous urticaria hives that persist for months or years on end. That level of chronic unprovoked skin inflammation is incredibly rare in early childhood.
So the researchers are looking at the adult checklist, which asks, does the patient have nasal polyps and chronic adult asthma? And they look at their 5-year-old patient who just has a swollen eye from ibuprofen, and they realize the checklist is asking impossible questions.
The adult system is built on comorbidities that simply do not exist in the pediatric landscape.
But the French study didn't just throw their hands up and say the adult system fails. They actually ran the numbers to figure out what the real pediatric risk factors are. If nasal polyps don't predict an allergy in kids, what does?
They conducted a multivariate analysis to isolate the specific variables that heavily correlated with a true NSAID reaction in a child.
And they found 2 massive predictors. The first was that if a child has a history of chronic urticaria, even if it's a pediatric version and not the lifelong adult version, it increases their risk of being truly hypersensitive to NSAIDs by a staggering 7.7 times.
That is a highly robust statistical correlation. It indicates that a child whose skin is already prone to inflammatory, histamine-driven reactions is sitting on a physiological powder keg when you introduce an enzyme-altering drug like an NSAID.
The second major risk factor they found is something called atopy, which increases the risk by 2.5 times. What exactly is happening in the body of an atopic child?
Atopy is a genetic predisposition. It means the child's immune system is naturally skewed toward an overzealous response to harmless environmental triggers. We often see this manifest as the atopic march in childhood.
What does that progression look like?
Well, an atopic infant might develop severe eczema early on. As they grow, that hypervigilant immune system might target food, resulting in a peanut or egg allergy. Later in childhood, it progresses to the respiratory tract, presenting as allergic rhinitis hay fever or childhood asthma.
So their immune system is perpetually primed for a fight.
It produces higher baseline levels of IgE antibodies and inflammatory cytokines.
So their immune system is constantly idling at a high RPM.
Yes. And the data clearly shows that this hypervigilant baseline makes them 2.5 times more likely to experience a chaotic inflammatory flood when an NSAID disrupts their metabolic pathways.
Okay, so we know the adult categories fail, and we know what the actual pediatric risk factors are. How did the medical community solve this taxonomy crisis? I mean, you can't just leave half your pediatric patients floating in a diagnostic void.
The solution came from the EAACI position paper, spearheaded by Kidon and their international team. They realized that a single classification system cannot stretch from infancy to old age. The human immune system is just too dynamic.
So they split the demographics.
It is an elegant, highly practical solution. They proposed a 2-tiered classification system based entirely on age and immunological maturity. For children under 10 years old, they created a highly simplified 3-group classification.
Because a toddler's immune system is fundamentally different from a teenager's.
Exactly. In young children under 10, almost all the genuine reactions are non-allergic pharmacological cross-intolerances, often heavily influenced by those viral cofactors we discussed. The pathology is relatively straightforward, so you don't need 5 complex adult buckets. 3 simple categories cover the vast majority of cases.
But once a child crosses that 10-year threshold, the rules change again.
For adolescents, aged 10 to 19, the new guidelines explicitly recommend graduating them into the adult-like 5-group system.
Why the shift at age 10?
Because of time and biology. By the time a child hits 10 years old, they are entering puberty. Hormonal shifts impact immune regulation. Furthermore, they have now been alive long enough for chronic conditions to begin taking root.
So they've had the time.
Right. An adolescent might start developing the early stages of chronic rhinosinusitis. Their childhood wheezing might begin cementing into structural, late-onset asthma. Their clinical presentation begins to mirror the adult phenotypes.
So we finally have a valid, scientifically sound way to classify these kids based on exactly how old they are and how their specific bodies react. But a classification on paper is only useful if you can officially prove the allergy in the clinic. Which brings us back to the diagnostic test itself.
The drug provocation test, the DPT.
Now, I know that anyone listening right now, especially if they are a parent, is screaming a very specific question at their audio player.
I can guess what it is.
We live in an era of unbelievable medical technology. We can sequence genomes. Why on earth are doctors intentionally giving a child a drug that might cause a severe reaction? Why not just do a simple skin prick test on their arm or draw a vial of blood and send it to the lab? Why risk the trauma of a live reaction?
It is the most frequent and frankly most understandable pushback pediatric allergists receive. To understand why we are forced to do the DPT, we have to lift the hood and look at the deep molecular mechanics of what is actually causing the swelling in the hives.
Okay, let's do it.
We have to draw a hard line between a true allergy and what we call pharmacological intolerance.
Let's explore that difference because it explains the failure of the blood tests.
When the general public thinks of an allergy, they are usually picturing a specific immune-mediated attack. Take a severe peanut allergy, for example.
Right.
In a peanut allergy, the child's body has mistakenly identified a specific peanut protein as a lethal invader. The immune system manufactures highly specific antibodies called immunoglobulin E, or IgE, that act like guided missiles targeting that exact protein.
So the body is armed and waiting.
The next time the child eats a peanut, the peanut protein enters the bloodstream, the IgE antibodies lock onto it, and that connection triggers mast cells to explode, releasing massive amounts of histamine. That histamine dump causes anaphylaxis.
And because that reaction is driven by those specific IgE antibodies, a blood test can easily spot them.
Exactly. You draw the blood, you count the peanut-specific IgE antibodies, and you have your diagnosis without ever giving the child a peanut. Or you do a skin prick test, introduce a microscopic amount of the protein, and watch for the localized histamine release. That is what we call a selective reactor. The immune system is selectively attacking the specific shape of the drug or protein molecule.
But these pediatric NSAID reactions are different.
They are utterly different in their biological mechanism. The vast majority of pediatric NSAID reactions are not driven by IgE antibodies. There's no guided missile. There's no targeted immune system attack against the ibuprofen molecule itself.
So if it's not an immune system attack, what is causing the child's eyes to swell shut?
It is a profound biochemical traffic jam caused by the drug doing exactly what it was designed to do. These children are what we call cross-intolerant.
Let's break down the mechanics of that traffic jam.
We have to look at the arachidonic acid cascade. Inside your cell membranes, you have a fatty acid called arachidonic acid. Think of arachidonic acid as a massive, fast-flowing river inside the body.
Okay, a river. Got it.
Under normal, healthy conditions, that river flows downstream and encounters an enzyme, specifically our friend COX-1.
Cyclooxygenase 1.
Right. COX-1 acts like a massive hydroelectric dam on the river. It takes the flow of arachidonic acid and converts it into prostaglandins. These prostaglandins are vital housekeepers. They protect the lining of your stomach, they regulate kidney function, and they manage baseline inflammation.
So the river is flowing, the dam is processing the water, and the body is happy.
Now, a child has a fever, and you give them an NSAID, like ibuprofen. The entire pharmacological purpose of an NSAI is to shut down the COX enzymes to stop inflammatory prostaglandins from being made. The drug enters the system and essentially drops a massive concrete blockade right in front of the COX-1 dam.
The dam is shut.
But the arachidonic acid river doesn't stop flowing just because the dam is shut. The raw material keeps coming. So where does all that biochemical water go?
It has to spill over somewhere.
Exactly. The arachidonic acid backs up and the river overflows its banks. In children who are cross-intolerant, they have an underlying genetic quirk in their metabolic plumbing. When the main river is dammed up, all that backed up arachidonic acid gets forced down a secondary alternative pathway. It floods into the lipoxygenase pathway or the LOX pathway.
And what happens when the LOX pathway gets flooded?
The LOX pathway takes all that overflow and converts it into chemicals called leukotrienes. And this is the disaster. Leukotrienes are incredibly potent inflammatory mediators. They are thousands of times more powerful than histamine at causing smooth muscle contraction and vascular leakage.
So the leukotrienes fled the system, they cause the blood vessels in the skin to leak plasma, creating those massive hives and the severe angioedema around the eyes. If they flood the lungs, they cause the airways to violently constrict, causing wheezing and asthma attacks.
Exactly. It is a massive inflammatory cascade, but notice what was completely absent from that entire process.
There were no IgE antibodies.
None.
The immune system wasn't attacking the ibuprofen. The ibuprofen was just acting like a concrete block on a dam, and the child's underlying metabolic plumbing routed the overflow straight into a leukotriene disaster.
That is precisely it. It is a pharmacological flood, not an allergic attack. And because there are no IgE antibodies involved, running a blood test or a skin prick test is entirely useless. You are drawing blood to look for a guided missile that doesn't exist. The blood test will come back perfectly negative, even if the child is highly reactive and in danger.
I do want to clarify one thing from the sources, though, because they mentioned a few rare exceptions where skin tests are used.
Yes, there are extremely rare exceptions. There is a specific drug used in some parts of Europe called metamizole, and very occasionally with paracetamol, where a child might actually have a true selective IgE-mediated allergy to the drug molecule itself. In those incredibly rare instances, a skin test or a specialized blood test might show a positive result.
But for the vast majority of kids reacting to standard ibuprofen or aspirin?
For the vast majority, the skin and blood tests offer zero diagnostic value, which leaves the allergist with only one option to prove what happens when the dam is blocked. You have to give the drug and watch to see if the river floods.
You have to do the drug provocation test.
You have to intentionally provoke the metabolic failure under intense microscopic medical supervision.
If you've ever sat in a hospital waiting room while your child is undergoing a medical test, you know the anxiety. But the protocol for a DPT sounds like a completely different level of intensity. Walk us through exactly what happens on the day of a test.
It is not a casual clinic visit. It is a highly orchestrated medical event. It must be conducted in a dedicated hospital or clinical setting. Before the test even begins, you must have pediatric resuscitation equipment, a full crash cart in the room, along with personnel trained in pediatric advanced life support.
Because if the river floods, it can flood fast.
Precisely. In the days leading up to the test, the child must stop taking all antihistamines or baseline asthma medications. You cannot have suppressive drugs in their system that might mask the early signs of a reaction.
So they are completely unmedicated. How do you give them the drug? You don't just hand them a full pill and set a timer, right?
No, you use an escalating dose protocol. The doctor calculates the full therapeutic dose based on the child's exact weight. But they start by administering a tiny fraction of that, usually 1/10, sometimes as small as 1/100th or 1/4 of the full dose.
So a microscopic amount, and then?
Then the waiting begins. The medical team observes the child continuously for 60 to 90 minutes. They are monitoring vital signs, checking the skin for the faintest sign of a wheal, listening to the lungs for the subtle, high-pitched whistle of early airway constriction.
If the 90 minutes pass and the child is fine,
they administer the next escalating dose. And they wait again. They repeat this latter process throughout the entire day until they reach the full cumulative therapeutic dose.
And if at any point the child starts to break out in hives or their eyes start to swell,
the test is immediately halted. Rescue medications are instantly administered. Intravenous antihistamines, powerful corticosteroids, or intramuscular epinephrine if there is any sign of severe respiratory distress or anaphylaxis.
It sounds utterly exhausting for the child and terrifying for the parents. And one of the most fascinating details from the multi-center study is that there isn't actually a single universally agreed upon way to do this across Europe. The protocols diverge wildly depending on what city you are in.
It highlights a significant ongoing debate in the allergy community regarding delayed reactions. Most major centers, like those in Geneva and Florence, utilize a one-day DPT protocol. They escalate the doses, reach the full amount, observe for a few final hours, and send the patient home.
But Madrid does it differently.
Madrid utilizes a 2-day DPT. They conduct the escalating dose protocol on day 1. Then they require the child to return the very next day, and they administer the full therapeutic dose all at once, just to be absolutely certain the metabolic pathways aren't slowly backing up.
And the clinics in Belgrade go even further than that. They run a 3-day test.
Yes. The researchers in Belgrade published data showing that a significant portion of their pediatric patients did not react immediately. They found that 30% of the children who eventually had a confirmed reaction only manifested symptoms on the second day of continuous dosing, and 20% didn't react until the 3rd day.
Wait, really? So if those children had been tested in Geneva or Florence on a one-day protocol, they would have passed. The doctor would have signed a piece of paper saying, "You are not allergic, go home."
They would have received a false negative. And 2 months later, when the child got a bad flu and took ibuprofen for 3 days in a row to manage the persistent fever, the leukotriene flood would eventually overwhelm their system, resulting in a severe, unexpected reaction at home.
Which is incredibly dangerous. So the rigorous, multi-day nature of these tests in places like Belgrade is essential for absolute patient safety. But let's look at the logistics of this for a normal family.
The logistical burden is immense.
Say your child is suspected of an ibuprofen allergy. You go to the hospital for a 2-day DPT. The doctor administers the ibuprofen, and on day 2, the child's eyes swell shut. The doctor stops the test and says, yes, your child has a true pharmacological cross-intolerance to classic NSAIDs.
The diagnosis is confirmed.
But you can't just go home and live a life where your child is never allowed to have pain relief or fever reduction. You have to find a safe alternative.
Exactly. The official EACI guidelines explicitly state that management frequently requires more than one provocation procedure.
Which means weeks later, when the child has recovered, you have to bring them back to the hospital, set up the crash cart again, and run another 2-day escalating dose test on a completely different drug, like high-dose paracetamol, just to see if their specific metabolic plumbing can handle it.
And if they react to that alternative, you have to come back a third time to test a different class of drug entirely.
Families might have to endure 3 or 4 separate, grueling, multi-day hospital admissions just to find one safe bottle of liquid they can keep in their medicine cabinet for a routine childhood fever. The investment of emotional energy, time off work, and medical resources is just staggering.
It is a massive trial of endurance.
Yeah.
But it is the only scientifically valid way to navigate the final and most critical phase of this entire ordeal.
Which is life after the diagnosis. Let's say you survive the gauntlet of testing. The doctor sits you down and confirms that your child is firmly in that 20%. They have a genuine leukotriene flooding cross-intolerance to classic NSAIDs. It is not a viral illusion. What happens the next time they get sick?
This is what the EAACI task force calls the management maze. Because the reality of childhood doesn't stop just because of a diagnosis. These children are still going to contract fevers. They're still going to sprain their wrists falling off a bicycle. They need effective, safe relief.
Let's split this into 2 categories. Fever first. It is the most common childhood symptom. If you cannot give them a standard effective dose of ibuprofen to bring a raging fever down, what are the options?
The first line of defense, recommended by the guidelines, bypasses pharmacology entirely. It relies on physical cooling.
We are talking about old-school remedies.
Exactly. Bathing the child in tepid water, applying cool compresses to the forehead and pulse points, lowering the ambient temperature of the room, and ensuring aggressive oral hydration with cooled liquids.
What is the actual mechanism there? Why does water on the skin lower the core temperature?
It is basic thermodynamics combined with vascular physiology. When the body has a fever, it is raising its internal thermostat to cook off the virus. When you apply tepid water to the skin, 2 things happen. First, the water evaporates, which physically draws heat energy away from the body. Second, the slight cooling of the skin surface promotes vasodilation in the peripheral blood vessels, allowing more of the hot core blood to circulate near the surface where the heat can be radiated away.
Oh, that makes a lot of sense.
It is highly effective, and it completely avoids the risk of a pharmacological flood.
But the guidelines also detail a really fascinating pharmacological loophole for fever management. It involves paracetamol.
Yes, and this relies entirely on understanding dose-dependent enzyme inhibition.
Earlier, we established that a child in Rome might react to paracetamol just like they react to ibuprofen, because paracetamol also pokes at the COX enzymes. So why would the guidelines suggest giving it to a diagnosed hypersensitive child?
Because of the dosage required to achieve different effects. If you give a child a high dose of paracetamol, you are significantly inhibiting those COX variant enzymes. You build a big dam on the arachidonic acid river, the river overflows, the leukotrienes flood the system, and you get hives.
Right.
But fever reduction entopyresis requires far less pharmacological power than inflammation reduction. To simply tell the hypothalamus in the brain to lower the body temperature, you only need a low dose of paracetamol.
And a low dose doesn't build a big enough dam.
Precisely. A low antipyretic dose of paracetamol only partially blocks the enzymes. It builds a very small dam. The vast majority of the arachidonic acid river continues to flow normally down its primary pathway. There is no massive overflow into the lipoxygenase pathway and therefore no leukotriene flood.
Oh, wow.
The clinical data shows that the majority of these highly cross-intolerant children can safely tolerate low-dose paracetamol for fever without triggering an allergic response.
That has to be a massive relief for parents navigating this maze. But a fever is only half the battle. What about acute pain and inflammation? If a hypersensitive 10-year-old twists their ankle severely, a tepid washcloth isn't going to stop the joint from swelling to the size of grapefruit. And a low dose of paracetamol isn't going to touch the deep inflammatory pain.
For significant pain and inflammation, the guidelines point to a very specific class of drugs as the absolute best, most scientifically elegant alternative. They're called COX-2 specific inhibitors.
Let's go back to the enzymes.
Let's look at the roles of COX-1 and COX-2. COX-1 is the housekeeper. It is always running in the background, making prostaglandins that protect the stomach lining and regulate blood flow. COX-2 is the emergency responder. It is usually dormant, but when tissue is damaged, like a sprained ankle, COX-2 ramps up massive production of inflammatory prostaglandins, specifically at the site of the injury.
So classic NSAIDs like ibuprofen are blunt instruments. They bomb both the housekeeper and the emergency responder.
Yes, and blocking the COX-1 housekeeper is what dams up the main arachidonic acid river, causing the overflow and the allergic reaction.
So what does a COX-2 specific inhibitor do?
It acts as a pharmacological sniper. Drugs like celecoxib or atorcoxib are engineered to completely bypass the COX-1 enzyme. They leave their housekeeper alone.
Right.
The main river of arachidonic acid continues to flow flawlessly, protecting the stomach and avoiding any leukotriene overflow.
But it takes out the emergency responder.
Exactly. It specifically binds to and blocks the COX-2 enzymes at the site of the sprained ankle, halting the inflammation and the pain without disrupting the baseline metabolic plumbing of the entire body.
That sounds like an absolute miracle drug for these cross-intolerant kids.
Scientifically and immunologically, it is. The clinical provocation trials prove it beautifully. When they give COX-2 specific inhibitors to these highly hypersensitive confirmed allergic kids, the drugs are proven safe and well tolerated in 80 to 85% of cases. It solves the biological problem almost entirely.
But practically,
we run into a massive, frustrating hurdle involving pediatric pharmacology and regulatory economics.
This is the catch-22 mentioned in the texts. What's fascinating here is that if you have a child in agonizing pain and you know there is a drug that will safely reduce the inflammation without causing their eyes to swell shut, you want to give them that drug. But you probably can't. Why?
Because almost none of these COX-2 specific inhibitors are officially approved by global regulatory agencies, like the FDA or the EMA, for use in children under 12 years old.
Wait, why aren't they approved? Is there a hidden danger for kids?
It isn't necessarily a hidden danger. It is a lack of pediatric clinical trial data. These COX-2 inhibitors were developed and brought to market primarily to treat massive adult demographic conditions, specifically chronic pain from osteoarthritis and rheumatoid arthritis.
The aging population.
Yes. The pharmaceutical companies spent billions of dollars running clinical trials on 50, 60, and 70-year-old patients to get the drugs approved for arthritis. Running dedicated, massive, double-blind, placebo-controlled trials on 8-year-old children just to get approval for occasional sprained ankles or minor surgical pain is an ethical minefield.
We can imagine.
It requires complex parental consent, the liability is astronomical, and frankly, the financial return on investment for the pharmaceutical company is relatively negligible compared to the adult arthritis market.
So the trials just don't happen.
They rarely happen. And because the drugs aren't officially approved for the pediatric market, pharmaceutical companies do not manufacture pediatric formulations.
Meaning there are no liquid syrups.
Exactly. There are no brightly colored, fruit-flavored liquid suspensions that a 6-year-old can easily swallow. You have a science-backed miracle drug, but it only exists as a massive hard capsule designed for an adult with arthritis.
So if an allergist knows this drug will work for their cross-intolerant pediatric patient, what are they supposed to do? Tell the kid to tough it out.
No, doctors are forced into a gray area of medicine known as off-label prescribing. They use their clinical judgment to prescribe the adult drug for a pediatric condition.
How does that actually work in practice? I mean, you can't just give a kid an adult pill.
It requires immense logistical effort. The doctor has to calculate a fractional dose of the adult capsule based on the specific weight of the child. Then they have to instruct the parents to break open the capsule, extract a very specific portion of the powder, and attempt to mix it into applesauce or pudding so the child can choke it down.
Which sounds incredibly imprecise.
It introduces a massive margin for human error in dosing. The alternative is sending the parents to a specialized compounding pharmacy, where a pharmacist manually grinds down the adult pills and suspends them in a liquid formula. But compounding pharmacies are expensive, they aren't covered by many insurance plans, and they aren't accessible in rural areas.
It is a staggering blind spot in modern medicine. We have mapped out the cellular immunology of these children. We have clinical data from provocation tests proving these specific drugs are safe in 85% of cases. But the regulatory frameworks and the pharmaceutical supply chains have completely failed to catch up to the immunology. The science is there, the logistics are failing the patient.
It is a critical unmet need that the EACI task force heavily highlights. We desperately need age-appropriate, officially regulated liquid formulations of these life-saving alternative medications.
Now, before we wrap up this massive journey, I want to touch on one other management strategy, because if you read about adult allergy management, particularly for things like aspirin, you constantly hear about desensitization.
Yes. Drug desensitization is a very powerful tool in adult allergy clinics.
The way I understand it, if an adult has a known, proven allergy to a drug, doctors will admit them to an intensive care unit and slowly, meticulously administer microdoses of that drug over a period of hours or days. They incrementally increase the dose, essentially tricking the immune system or exhausting the metabolic pathways until the body finally gives up and accepts the drug without reacting. They desensitize the patient.
That is a very accurate description of the process. You are overriding the hyperreactive pathways.
So if a 10-year-old has a cross-intolerance to ibuprofen, why don't we just admit them to the hospital, run a desensitization protocol, and cure them? Then they could just take ibuprofen for a fever like a normal teenager for the rest of their lives.
It comes down to the foundational principle of all medical decision-making, the risk-reward ratio. Desensitization is not a cure. It is a temporary state of tolerance that requires daily, continuous dosing of the drug to maintain. And the procedure itself is inherently dangerous. You are intentionally pushing a patient's body right to the absolute edge of a severe allergic reaction, hovering just below the threshold of anaphylaxis for hours.
High risk.
Extremely high risk. Now look at the adult scenario. Why do we desensitize adults to aspirin? Because an adult with severe cardiovascular disease who has had a heart attack absolutely requires a daily dose of aspirin to prevent their blood from clotting and causing a second fatal heart attack.
The reward is preventing sudden death.
Exactly. The massive life-saving reward of the daily aspirin therapy justifies the high risk of the desensitization procedure. But children do not suffer from adult cardiovascular disease. A child does not need to take a daily NSAID to survive. They only need it occasionally for a sporadic fever or a random sports injury.
So risking anaphylaxis just so a teenager can occasionally treat a headache isn't worth it.
The risk unequivocally outweighs the reward. You do not subject a child to a potentially lethal desensitization protocol for convenience. You find a safe alternative, like physical cooling or an off-label TOX2 inhibitor instead.
The sources do mention one rare, terrifying exception to this rule for children.
Yes. Kawasaki disease.
What is Kawasaki disease?
It is a rare, severe childhood illness that causes massive systemic inflammation in the blood vessels throughout the body. The most critical danger of Kawasaki disease is that it severely inflames the coronary arteries that supply blood to the heart muscle itself, leading to potentially fatal coronary aneurysms.
Oh, wow. How do you treat it?
The primary non-negotiable treatment is prolonged, high-dose aspirin therapy to reduce the arterial inflammation and prevent the aneurysms from forming. If a child with Kawasaki disease is also fundamentally cross-intolerant to NSAIDs and aspirin, which is an exceedingly rare statistical collision, then the pediatric cardiologist and allergist are forced into a corner.
In that case, the reward is preventing a pediatric heart attack.
Yes. Only in that extreme life-or-death scenario would a medical team undertake the massive risk of running a pediatric desensitization protocol. But for the standard pediatric patient, the procedure is strictly avoided.
It is entirely about balancing the scales of risk. Okay, we have covered an absolute mountain of immunological and clinical ground today. Let's synthesize this journey.
It is a complex, often counterintuitive landscape, but the takeaways are profound for anyone navigating pediatric healthcare.
We started by dismantling a massive clinical illusion. We learned from the European multicenter data that a staggering 80% of perceived pediatric NSAID allergies are actually false alarms. They are illusions of causality, where a crucial life-saving drug is unfairly blamed for inflammatory rash that was actually caused by the chaotic immune response to a perfectly normal childhood viral infection.
We discovered that when we isolated the 20% of children who were truly reacting, the established adult medical classifications failed spectacularly. We learned that the pediatric immune system is a blank slate, devoid of the decades of chronic inflammation required to develop adult conditions like nasal polyposis, necessitating a brand new, age-based diagnostic framework from the EAACI.
We lifted the hood on the biochemistry of these true reactions, exploring the arachidonic acid river. We learned that these aren't traditional antibody-driven allergic attacks, but rather massive pharmacological traffic jams that flood the body with potent leukotrienes. This metabolic reality makes standard skin and blood tests entirely useless.
Which forces families to endure the grueling high-stakes, multi-day endurance test of the drug provocation test just to get a real answer.
And finally, we navigated the management maze, uncovering the profound logistical frustrations of having scientifically proven alternative medications like COX2 inhibitors, trapped behind adult-centric regulatory walls, forcing pediatricians into off-label prescribing just to relieve a child's suffering. If you are listening to this, whether you are a parent who has stared in panic at a bottle of children's ibuprofen at 2 a.m, or an inquisitive mind fascinated by the hidden mechanics of immunology, or even someone who has grown up strictly avoiding a specific medication because of a story your mother told you about a rash you had when you were 3 years old, remember this. A medical label is a powerful thing. The word allergic dictates your care. It shapes your options. But shedding a false label driven by accurate scientific testing can fundamentally change your relationship with healthcare.
Knowledge dictates options. And in medicine, having safe, accessible, effective options is everything.
So what does this all mean for us outside the clinic? I want to leave you with a lingering thought to mull over. We know from this modern data that over 80% of pediatric NSAID reactions are misdiagnosed, written off as allergies when they were really just a toddler's immune system fighting a routine virus. But think about the timeline of this research. These massive European studies and guidelines clarifying all of this are relatively recent.
Which implies a massive historical backlog of unquestioned diagnoses.
Exactly. Think about the generations before this data existed. How many adults in the world today, maybe people sitting next to you on a train, maybe your own family members, are walking around right now strictly and fearfully avoiding cheap, highly effective, potentially life-saving medications like ibuprofen or aspirin? How many are taking unnecessary medical risks or paying for expensive alternatives based entirely on a false alarm that happened when they were 3 years old? How many of us are unknowingly living with medical ghosts from our childhood, dictated by a viral rash we don't even remember? It might just be time to critically evaluate our own medical histories. Until next time, keep digging.